Good afternoon, everybody, and hope you had a great 4th of July weekend. Dr. Michael Jacobs here with our Monday afternoon Instagram chat. Today's topic is fertility medications, how they work, and when to use them. The first thing that's very important to know about fertility drugs is that the name fertility drugs is sort of a misnomer. We use them in the treatment of infertility, but they're basically ovulatory drugs. People refer to them as fertility drugs because they're used in the treatment, but they're really ovulatory drugs, and we have to remember that when we use them to know what we're trying to accomplish. If you look at ovulatory drugs, they come in two basic varieties. There are the ovulatory drugs that are used orally, taken by mouth for 5 days in a cycle. And this is Clomid predominantly, clomiphene citrate, that's been around for over 40 years. And the others are Femara, or letrozole, which is also an oral ovulatory drug. The difference between the two is that they accomplish the same thing but in a different manner. Clomid is an FDA-approved drug for the treatment of infertility. Femara works just as well as Clomid and may even work better, particularly in patients with polycystic ovaries, to restore ovulation, but is technically an off-label use of the medication. It was developed as a anti-breast cancer drug, not a fertility drug, and because it's an aromatase inhibitor, it has the same basic effect as clomiphene in getting ovulation to occur in patients who don't ovulate properly. So the oral drugs are Clomid and Femara, and the injectable medications, the second variety of drugs, are directly stimulating the ovary to produce eggs. And those are medications that are called FSH or HMG. FSH stands for follicle stimulating hormone. HMG is human menopausal gonadotropin, which is actually a blend of FSH and LH activity, although pharmacologically the LH comes in the form of Hcg. So how do these drugs work? Clomid is an interesting medication. It's an estrogen blocking drug, and what it does is, particularly in patients who are not ovulating properly, it basically blocks the perception that you're producing hormone, estrogen, and as such, your pituitary gland stimulates the ovary to produce more FSH. So it causes the pituitary to function a little more normally, and by producing more FSH, you produce a better egg, and then in the middle of the cycle, you can get ovulation to occur, and then obviously if ovulation is occurring, you can get pregnant. Femara, letrozole, does the same thing. It just, instead of sitting on an estrogen receptor, just decreases estrogen levels. The result is the pituitary makes more hormone, stimulates the ovary better to get a better egg being produced. The injectable fertility drugs are directly stimulating the ovary. If you remember the system, you have part of the brain called the pituitary that releases hormone called FSH to stimulate the ovary. The ovary then produces an egg and makes estrogen. Once the egg is ovulated, the ovary then makes progesterone. The estrogen and progesterone provide the hormonal mix to get the lining of the uterus to develop normally and an embryo to be allowed to stick. So if you're not ovulating properly, one needs to use one of these medications to restore what's not happening normally. And the original use of these medications and the reason that they were devised was to get ovulation to be restored. So the first indication for use of these medications is to restore ovulation in a patient who either doesn't ovulate at all or somebody who has an inadequate ovulation. Patients who don't ovulate at all usually will present with very, very irregular cycles. They'll tend to have polycystic ovaries a lot of the times. The patients that tend to respond well to oral fertility drugs or oral ovulatory agents, clomiphene or letrozole, are the ones that get periods every once in a while, or if challenged with progesterone, Provera or Agestin or Prometrium. If you haven't gotten a period in a while and your doctor gives you progesterone and your period comes down, that implies that at least the system is partially working. This feedback mechanism between the brain and the pituitary is functioning okay, and it's just not ovulating. So it's partially working, and what the Clomid or the Femara does is allow us to fine-tune that. So in the first good indication for using these medications are in a patient that doesn't ovulate properly to restore ovulation. There's also a subgroup of patients that ovulate, but once they ovulate, they don't produce an adequate amount of hormone to adequately support an embryo that may be trying to stick. And this falls in a category of what's called luteal phase insufficiency or luteal phase defect or ovulatory dysfunction. And this group also will benefit from the fertility drugs. In the latter group, you can either sort of treat the horse after it left the gate by giving some added progesterone, or try and produce a better horse to start with, which is using the fertility drugs to get a better egg out. So in patients who both ovulate but don't have adequate support of the ovulation to allow implantation to occur normally, or in patients who don't ovulate at all, the use of these oral agents is a great first-line approach. The medications are usually given 5 days in a month. Our preference is not to use them blindly. They do purposely cause cysts on the ovary because that's where the eggs live. You don't want to really use them in patients with ovarian cysts like endometriosis without knowing that they're there. You don't want to use them in patients who've not been evaluated previously or had ultrasounds because there are cysts present. They can make them worse. So in our practice, our preference is to do a baseline ultrasound prior to treatment. The ultrasound is meant to make sure the uterus and ovaries are normal, and most importantly, that there are no significant ovarian cysts present that would contraindicate the use of these medications. The ultrasound exam is usually done on the second or third day of the cycle. It can be done as late as day 5, and in patients who don't ovulate at all, it can be done pretty much any time, because in that subgroup of patients, every day is like day 3 or 4 of the cycle. So if we have one of the latter patients who's not ovulating properly, who hasn't gotten a period in 2 or 3 months, the question is, do we need to bring down a period before starting them? It depends how thick the lining of the uterus is and what their hormones look like. If the lining is thin and the estrogen and progesterone is low, we can just start them up. If the lining is very thick, then it's good to cleanse the uterine lining beforehand, or else it might be too thick to allow an embryo to stick down the road. But in general, we'll see patients either the second or third day of the cycle. We do an ultrasound. We often do not need to do blood tests at the beginning of the cycle. So it's mostly an ultrasound to make sure there are no cysts present. If that's okay, you use the oral medication from the 3rd to the 7th day of the cycle, or on, if needed, day 4 to 8 or 5 through 9. But on days 3 through 7, you take this medication. Now, the dose of medication will vary from 1 tablet to 5 tablets a day. So with Clomid, that's a dose of 50 to 250 milligrams a day. With Femara, it's a dose of 2.5 to 12.5 milligrams a day. And we usually start out with a low dose and work our way up when we're treating ovulatory dysfunction. And the reason is that the goal in somebody who's not ovulating properly is to restore what happens naturally. And what happens naturally in a given cycle is that a woman ovulates 1 egg. So our goal is to restore that normal function where ovulation is occurring and 1 egg is being produced and 1 egg is ovulating. We're not trying to get 3 or 4 eggs out. We're not trying to get multiple pregnancies. We're trying to restore what's happening normally so that the rest of the system can work. We like to make sure that these medications are working. And if you don't get pregnant, we'd like to know why. We'd like to know, is it a failure to respond to the medication at the dose we gave you? Did you not make an egg or a follicle, which is the lake of fluid that the egg sits in? Did that occur, but ovulation just not take place, or did everything work properly? Just we didn't get pregnant that cycle. No different than you ovulated on your own and didn't get pregnant in that month. So the way we monitor the medications, we do a baseline ultrasound on the second or the third day. You would start medications usually on the third day of the cycle. We bring you back on the 13th day of the cycle, which is when we should see the lining thickening up, and we should also see that the ovary is producing follicles. And ideally, we'll see a leading follicle in the 17 to 20 millimeter range. People can ovulate with follicles as small as even 15 millimeters, large as 25. The sweet spot we're looking for is 18 to 20 millimeters as the right time to get ovulation to occur. We do have patients utilize an ovulation predictor kit, usually beginning around the 11th day of the cycle, counting the first day of flow as day 1. And the reason for that is that some people might try and ovulate early on us. And so by doing that, we're going to catch the patients who are trying to ovulate early most of the time. If those kits are positive, we'll bring you in sooner and do an ultrasound and blood test. If those kits remain negative after the initial ultrasound on day 3, the next time we see you is on day 13. And if we start you on day 4, it's day 14, day 5 is day 15. So we bring you back mid-cycle. We're looking to see that there's a follicle present. We make sure that your ovulation test kits at home have been negative to date. And we also do blood tests to measure estrogen and progesterone ideally, and that helps us assess how close we are to ovulation and whether the follicle present is working as we expect it to. If everything looks good, then we prefer to use a medication called Hcg to trigger ovulation. And this just helps us let you know when you're going to ovulate within a 12-hour window usually, because most people will ovulate between 36 and 50 hours after the Hcg is first provided. So this is helpful in knowing when to have sex, basically, with your partner, and it's very helpful for us to know when to inseminate if we're assisting with intrauterine insemination. Do we need the latter? Depends what we're treating. If the only problem is you're not ovulating properly and you haven't been on these medications before, and your partner's sperm is 100% normal and relations are not a problem, then certainly we can try for a few months with timed relations, just telling you, okay, we're giving you this medication on Monday, you're going to ovulate on Wednesday, have sex on Wednesday, and let's see what happens. In patients that haven't gotten pregnant after a few months of timed relations, someone who hasn't gotten pregnant within the first few months with just time relations, or if there's any abnormality on the semen analysis, whether it be a low count or a low morphology or a low motility, then doing inseminations will help us improve the pregnancy rate. If you go back 10 years, we used to do 2 inseminations 24 hours apart, but the scientific data really didn't support that. And 1 well-timed insemination approximately 36 hours after the Hcg injection is the best time to have relations or do an insemination. It's important that if you have medication hanging out at home, you check the expiration date. We don't recommend you use medications that have been donated by friends and so forth. You shouldn't use any medication where the date has expired, basically. If we see that you're responding by making too many eggs, let's say you're on a dose of medication and you respond, you're making 4 or 5 dominant follicles instead of just 1 or 2, that's a cycle where we may recommend that you don't get pregnant on, because we don't want you to give birth to triplets or quadruplets. And the risk of multiple birth with these oral medications in general is about 8%. Most of those are twins. The risk of triplets is about 1 in 1,000. But still, if we see 4 or 5 dominant follicles present, then that's not a good cycle to try and get pregnant on, because it's too high a risk of a high order multiple pregnancy. High order multiples are associated with premature delivery, premature labor, and complications in the newborn secondary to that. So we try and avoid that from happening. Most people will respond to a dose of either 50 or 100 milligrams of Clomid, which are 1 or 2 tablets, and I'm sorry for the backup noise there from the computer guys. And so 80% of people will respond to 1 or 2 tablets a day of Clomid by producing an egg to ovulate. And the patients that do not, we can go to higher doses of the medication. But in general, most 80% of patients will respond to some dose of Clomid. If you don't respond to clomiphene, we can try Femara or vice versa. If you're not responding to either of those, then you need injectable fertility drugs. Some patients fall into this category of a partial response where they'll produce some small eggs, or instead of producing the dominant follicle on the 13th or 14th day, they need 16 or 17 days for that to happen. And that's okay, but usually if we see that, we'll sort of change the dose next cycle. So the real important thing for us to evaluate mid-cycle is, do we need to change the dose of the medication? Is the lining of the uterus okay? Are we getting the timing right for either relations at home or intrauterine insemination? So all the stuff we do to monitor you is twofold. One, to optimize the pregnancy rate in the cycle that we're treating you, as well as in the second case, what can we do different if you don't get pregnant? Now, the chance of getting pregnant in a cycle where we restored ovulation in somebody who doesn't ovulate properly is the same success rate that you would get if you were ovulating normally and you just decided to have sex with a partner and said, okay, let's see what happens. And in a young person, it'll be 20%. In somebody in their 30s, it's probably 15%. In their mid-30s, and at age 40, it's about 10%. So we don't get too worried that this isn't working unless you're not getting pregnant with, 4 to 6 cycles go by, nothing's happening. Meaning you're ovulating, but you're not getting pregnant. We've tried insemination, still not getting pregnant. If you've gone 6 cycles where everything has worked, this isn't going to work to get you pregnant. And at that point, we either can progress to injectable fertility drugs or even consider in vitro fertilization as a means of treatment. There's a subgroup of patients that we're treating for unexplained infertility. These are couples where they ovulate normally on their own, they have reasonable sperm and the tubes are open, it's just unexplained why they're not getting pregnant. And doing an ovulatory drug combined with intrauterine insemination will increase the likelihood of getting pregnant over doing nothing. It doesn't get us to the same success rate that we would with these medications in somebody who doesn't ovulate at all, because in the not ovulating at all group, we've actually we've fixed what's broke. So you'd expect a normal pregnancy rate, whereas in somebody who has unexplained infertility, we're just kind of trying to fine tune it, and in some patients it works and in others it doesn't. But the goal when you're using these agents with insemination or timed relations is to restore what's happening normally. In patients with unexplained infertility, we might be a little more aggressive to try and get 2 or 3 eggs to ovulate in a cycle and be more tolerant of that situation, because the more eggs that get out, the better chance there is potentially of one of them fertilizing in that cycle and being a normal embryo when it's fertilized to result in a pregnancy. In patients who don't get pregnant with the oral medications, we have the ability to do what's called controlled ovarian hyperstimulation, or COH, combined with intrauterine insemination. And this is just moving things up a notch. Instead of using an oral ovulatory drug, we're using injectable medications. The injections are subcutaneous, so they're very, very tiny little needles. The FSH is a little pen device like an insulin syringe, so it's very simple to use. And the goal here is to produce 2 or 3 eggs ideally, certainly no more than that, and to time inseminations when pregnancy is occurring. And again, if you don't ovulate at all, if you're a PCO type patient, our goal is really 1 or 2 eggs. With unexplained infertility, 2 or 3 is reasonable. No anything over 3, we have a discussion on the risks of multiple birth. Now, remember, we're not transferring eggs or embryos here, we're just getting them to ovulate. So there's not an issue of how many eggs do we recommend implanting, it's how many eggs potentially are going to ovulate in that cycle. And if you're 43 or 44, the odds of any egg working is much less than if you're 25. So we may be a little more tolerant of somebody older responding by producing more eggs than somebody younger, where the chance, once ovulation occurs, of that single follicle resulting in a good egg that results in a normal embryo that's going to implant is a lot higher. The injectables directly stimulate the ovary, and as such you tend to have a higher response. In contrast to people who have no response to Clomid, you don't need an intact pituitary ovarian axis at all, or even one that's partially working, because we're directly stimulating the ovary. So we're giving the ovary the stimulation that the pituitary would normally provide, but in a different fashion. And as a result, it responds by making eggs, basically. In some patients who have a partial response to Clomid, where they begin to produce an egg but it doesn't grow big enough, that's the subgroup that really benefit from the combined approach. And if we're trying to do insemination or time relations, we'll tend to do that sequentially, where they start the Clomid for 5 days, and then we'll add a very low dose of injectables, with the idea that we're starting the eggs out with the Clomid, and then once they get started, we're going to add the injectables to kind of keep them moving a little bit. So that's our goal for insemination purposes, and I'll get to IVF in a few minutes. With the injectables, same thing, baseline ultrasound to make sure there are no cysts present. If everything looks okay, we start the medications on the 3rd day. The dose of medication is going to depend on a couple of different issues. The first is, are we treating somebody who's not ovulating at all? Are we treating somebody who we think is going to be very sensitive to medications? Or are we treating somebody who we think is going to be very resistant to medications? And the answer to those questions lie on the history that we've gotten from the patient, the tests that we've done to check AMH, FSH, LH, estrogen, the presence or absence of polycystic ovaries, the age of the patient, and any past responses the patient's had to these fertility drugs in the past. So by using that information, we can guesstimate what's the probably good dose to use. And in patients who don't ovulate at all, or very sensitive ovaries, polycystic type ovaries, we start with very low doses of medication and increase it slowly over time. In patients who are more resistant, we would tend to use higher doses of medication from the get-go. And again, the fear here is that because we're, in essence, stimulating the ovary directly with FSH, the response is going to be greater than with the oral medications. So we worry about too much of a response. And again, it's the same criteria. If we're trying to restore ovulation, ideally we want 1 or 2 eggs, because that's what people normally ovulate. If unexplained infertility, we go into that 2 to 4 range, and with IVF, it's a different approach totally. So to summarize, for ovulation disorders, first-line approach is either clomiphene or Femara or letrozole. With polycystic ovarian syndrome, there are some studies to suggest that Femara letrozole may give a little better pregnancy rate. In patients who are having thin linings as a result of the Clomid, then Femara letrozole might be a better approach. And in patients not responsive to the oral medications, either a blend of the two if they're having a partial response, or moving directly to injectable fertility drugs or ovulatory agents with FSH or Hcg would be the approach in that subgroup of patients. As far as what happens mid-cycle, if you do nothing, most people will ovulate in response to Clomid. We just don't know when. So our preference is to provide an HCG trigger in the middle of the cycle. And even if you have an ovulation surge that says, okay, I'm starting to ovulate, we still give the HCG trigger as a buffer to ensure a more adequate second half of the cycle. As also, it adjusts when we do the timing of insemination or recommend that you have relations. In general, if your LH kits are negative, we give you HCG in the evening, and 36 hours later we'll do an intrauterine insemination. If you're having an LH surge, then we probably will give you HCG that morning or that afternoon and inseminate you the next day. So we'll move it up because in essence the egg will ovulate when your LH reaches a certain peak. 24 hours later the egg will ovulate. And so if we see that you're beginning to set off that LH surge, you're going to ovulate sooner rather than later, so that's why we move things up. If you haven't had any significant LH surge, then it's going to be more in the 36 to 50 hours from when we give you that HCG injection, which is the onset of the LH surge naturally. The HCG is the LH as far as the ovary is concerned. With injectable fertility drugs, they're more complicated to use, they're more expensive, and you can have over-response much more easily than with the oral drugs, and that's why we start simple and get more complicated if we need be. The side effects of these medications differ. With clomiphene, besides the 8% risk of multiple birth and 1 in 1,000 risk of triplets, we see a little bit of moodiness, irritability, sometimes some hot flashes at the beginning when you're actually on the medication. Very rarely do we see marked overstimulation of the ovaries. It can happen, but it's much more unusual than with injectable fertility drugs. With the injectable medications, the biggest concern we have is over-response and ovarian hyperstimulation syndrome, which is when you can retain fluid, become dehydrated, potentially need to be admitted to a hospital. And that doesn't occur very commonly. It only occurs in even 1% of patients, but we try and avoid that as best we can. If you're on injectable medications and you're over-responding to the medications, we usually recommend canceling the cycle or possibly converting the cycle to an IVF cycle. In women with polycystic ovaries, a lot of them are very brittle. They'll go from no response whatsoever to an oh my gosh response very quickly, and that middle's fine line you just will never find, and so that subgroup, sometimes you're stuck having to do IVF. So the last category is, how do you use these ovulatory drugs with in vitro fertilization, and what is our goal and how is it different than restoring ovulation? And we said with ovulation, we're just trying to get 1 or 2 eggs to ovulate because that's what the body does normally. With in vitro fertilization, our goal is different. Instead of 1 or 2 eggs, we get a little greedy. We'd like 15 or 20 if we can. So we aim for 10 to 20 eggs in an IVF cycle. So we use higher doses of the injectable fertility drugs. And the reason that becomes important with in vitro fertilization is we know that not every egg is going to be a good egg. And this is whether you ovulate on your own or we aspirate them with in vitro. Not every egg is going to fertilize, even if it's a mature, good egg, basically. And not every embryo that initially forms will continue to develop. And then depending how old you are, a certain percentage of these embryos are just not going to be normal genetically. And again, that's whether you get pregnant on your own or you get pregnant with IVF. So because we don't have to worry about the risks of high-order multiple birth with IVF, and because we have the ability, by the way we stimulate people, to change the trigger of ovulation from Hcg to what's called lupron to get ovulation to occur, we can minimize even further the risk of hyperstimulation and safely get the eggs, fertilize them, grow the embryos out, have the ability to biopsy the embryos on the 5th or 6th day of development to know that they're genetically competent, and to consider putting those embryos back. So in patients that over-respond to fertility drugs, no matter what we do, IVF's the best alternative. In patients with unexplained infertility who don't get pregnant with a couple of cycles, or in patients where we've restored ovulation for 6 cycles and still they're not getting pregnant, they've got unexplained infertility, and then IVF makes the most sense. So with in vitro, the only difference is we're more aggressive with the dose of medication. Of course, our goal is different. We're not trying to get 1 or 2 eggs. We're trying to get 10 or 15 or 20 eggs, because that's going to give us the best opportunity for the patient to get pregnant at the end of the day. So that's a pretty good summary of how and when to use them. The drugs, the fertility medications, can all be used safely with minimal side effects. Most of them are tolerated very, very well by patients. Most patients, particularly with the oral medications, don't feel anything. With the injectables, they're a little more complicated because you have to inject them on a daily basis, and you need more monitoring. Whereas with the oral medication we see on day 3, we don't see it at day 13. Once we start adding injectable medications in, after 4 days of injectables, we usually start monitoring you so we can adjust the dose and fine-tune it based on what our goals are. And again, if we're trying to restore ovulation, our goal is 1 or 2 eggs. If we're trying to produce a batch of eggs for in vitro fertilization or for cryopreservation of eggs for fertility preservation, that again, we're trying to use higher doses of these medications to purposely get 10 or 15 or even 20 eggs if we can, to maximize the overall fertility from the cycle of treatment that we're getting. The key to these medications is they should be monitored. We're not big on just saying take these, and if you don't get pregnant in a couple months, come on back. They should not be used indiscriminately because they're not fertility drugs. If you give clomiphene to somebody who's ovulating normally, it can actually make it more difficult for them to get pregnant, not better, because it might thicken up the cervical mucus and make it harder for the sperm to penetrate to get up to the egg. So we don't recommend using them indiscriminately. We don't recommend using them without monitoring. We don't recommend using them without a baseline ultrasound to know that there are no cysts there that we're not going to make worse by using these medications. So it does require a little bit of work on the patient's side and on our side to use them safely. But the key take-home message is we can use these drugs safely to help you conceive. They're useful both in patients who don't ovulate at all, patients who ovulate but not strong enough, basically, and in patients where we're purposely trying to superovulate them, particularly to produce multiple eggs in preparation for in vitro fertilization or egg freezing. So it's a lot of information. A lot of our patients are on these medications at different times of their fertility treatment. They're all good medications. They've been around a long time. They don't cause birth defects. And the key is to use them safely, to use them in a monitored environment, and to understand what we're trying to accomplish with these ovulatory agents to maximize your fertility and to maximize the health of a nice singleton pregnancy and a healthy delivery. If you have additional questions, please let us know. Have some suggestions on topics you'd like us to address, let us know as well. And we look forward to taking care of you, of our patients, explaining this in more detail if need be. And our goal is to educate you, advise you, help you get pregnant, and wish you the best in your goals of accomplishing a family. So have a good afternoon, and I thank you for listening in.